Good afternoon, one and all. This is the most informative session, the last session of the 5 days International e-FDP, SDP on evolution in teaching, guiding values in learning and social understanding through research, organized by Gokhale Education Society, Dr. M. College of Pharmaceutical Education and Research, Nashik, in association with Indian Pharmaceutical Association, Nashik branch. We have a well-known academician in the field of pharmacy, especially if you say in the discipline of pharmaceutics, from Institute of Chemical Technology, ICT Mumbai, Dr. Vandana Patravale ma'am. I welcome Dr. Vandana Patravale ma'am in this session. Madam will talk on research direction. Is social dimension important in today's session? We have Mrs. Anupama Paranspe ma'am, librarian, Gokhale Education Society, Sir Dr. M.S. Gosavi College of Pharmaceutical Education and Research, Nashik, as a moderator. Welcome you, ma'am. We have Dr. R.A. Patil and Dr. S.S. Harak, coordinator of this e-FDP and SDP in boardroom. I welcome both of them. Now I request Mrs. Anupama Paranspe ma'am to introduce our guest or our resource person, Dr. Vandana Patravale madam. Madam, please, over to you.
Hello.
Yes, madam.
Yeah. Good afternoon, one and all. I, Mrs. Anupama Paranspe, on behalf of organizing committee member of this online FDP and SDP, extends a very warm welcome to all member delegates and invited guests. Now we are entering into the 10th and last session of this online FDP and SDP organized by GE Societies, Sir Dr. M.S. Gosavi College of Pharmaceutical Education and Research, Nashik, and Indian Pharmaceutical Association, Nashik branch. It's my privilege to introduce speaker of the session, Dr. Vandana Patravale, Professor Pharmaceutics, Institute of Chemical Technology, Matunga, Mumbai. She completed M.Pharm in Pharmaceutics from University of Mumbai in 1987 and did PhD in Pharmaceutics from University of Mumbai in 1992. She has 30 years experience, out of which 17 years PG and 18 years in research. Her collaborations include at international level with Switzerland, Japan, UK, USA and Berlin, and at national level TIFR, BARC, NIRRH, NIIH, IIT Mumbai, Government Dental College Mumbai, CDRI Lucknow. Her contributions to the field of pharmacy includes: Madam received Professor Indira Parikh 50 Women in Education Leaders Award in 2018. Shri Amrut Modi Distinguished Researcher Award in 2018. UGC BSR Mid-Career Award Grant in 2018 and Gandhian Young Technological Innovation GYTI Award in 2018. Women Scientist Award 2015 by OPPI in 2015. VDU PCP Pharmacy Teacher of the Year Award in 2012. Recently, she got 2 industry projects in nanoformulations and 2 DBT projects in COVID diagnosis and vaccine. She guided 45 plus PhD students and currently supervising 8 PhD projects. Madam supervised 50 plus M.Pharm dissertations and 20 MTech projects. She is an editor of CRS Newsletter Indian Chapter, Associate Editor for Journal of Nanoscience and Nanotechnology, and Guest Editor for Drug Delivery and Translational Research. She has total 7713 citations, 44 H index and 105 I-10 index. Welcome, ma'am.
Thank you.
Title for the session is Research Direction. Is Social Dimension Important? Now I request Madam to start the session. Over to Dr. Vandana Patravale, Madam.
Thank you, Anupama Madam, for the kind introduction, a very elaborate one. So, give me some time to share my slide. Is it visible?
Yes, madam. Yes, madam.
Yes.
So full screen visible now?
Yes, madam. Yes.
Okay.
Yes.
So as indicated, my topic today is research direction. Is social dimension important? I think we are now in an era, and right now with this COVID situation prevailing, all of you know answer to this particular question. Yes, social dimension is very, very important. And I would like to really compliment the organizers for selecting such a topic wherein people are exposed not only to different teaching, pedagogy, and learnings, but also they are trying to look at how, through research, through social understandings, we can cater to so many numerous problems which world is facing today. Already elaborate introduction has been given by Mrs. Anupama, but definitely I would like to acknowledge Institute of Chemical Technology, which has given us wings to fly. What we need to do as far as this topic is concerned is prioritize One Health if we have to manage any disease outbreak. What do we mean by One Health? One Health is a concept which WHO is promoting so that we come up with remedies which not only actually are useful for human beings but also for animals. So One Health concept needs to be prioritized. There is re-emergence of infectious diseases. Earlier, it was MERS, then came SARS, and now it is COVID. All are related diseases and they are re-emerging. There is risk of global spread, obviously, because of the travel, because of innumerable issues, which world is going through now. There are many people at risk. There are many potential risk groups. And I'm sure today everyone knows which are the high morbidity groups. So there's increased burden of 21st century epidemics. We need to contain these outbreaks. So we have to come up with diagnostic methodologies and come up with therapy modules so that we have something which can tackle all the issues. As you can see in this slide, WHO has given a guidance on epidemic phases and its responsive interventions. It is said that global health security is a very, very severe concern today. We need to protect health and we need to see that there is social disruption majorly so that the infectious diseases do not get promoted. Not only that, if you look at the down panel, wherein we are showing that if early detection is done, of course, it can be curbed. But if not, there's localized transmission. If this is also not curbed, which happened now in Indian situation, there's amplification. So we were claiming to be down the ladder, in COVID cases. And now if you see the statistics, we are on top. Why? Because control and mitigation has been an issue. So obviously, if we can control it, it will totally be eliminated or eradicated. So not only it has, the social dimension, now, it also has political dimension and economic impact. As more and more people are getting affected, economy is severely getting affected. And people have already started blaming China for bio-warfare. So that is a political dimension to it. So we need to curb all this, and WHO has very good guidance. So in your spare time, I always suggest people something, and this time I will suggest that WHO is also giving you some good certificate courses. And for all frontline workers, this Chichi, I call it as Chichi, there are many such verdicts given, programs given, which can definitely benefit coordinating responders. It gives lot of health information, gives who is at risk and how those risks need to be mitigated, and what kind of intervention should be done so that this does not get propagated further. So there's a very good PDF. I've given you the link at the bottom. One could actually look at that link, and then, you can go ahead with the knowledge. Where is the world headed? Look at this slide. This depicts what are top 10 causes of death. So obviously, if you cannot do much in case of, say, ischemic heart diseases, etc., definitely number 4 to 7 are in our hand. Can we not do anything for diarrhea, respiratory infections, tuberculosis, neonatal disorders? Majorly it is the Asian and in particular Indian population, which is really showing high numbers here. And definitely we can direct our research in that direction. If you look at the demographics and infectious diseases, if North America is at 579 millions, this is of course a little old data, 2016 data, you can see that Asia is 4,463 billion infectious diseases people, worldwide getting affected, and in particular Asia getting affected. So if that is the number, it's only you and me who are going to work, because people in the West, now they have awakened, with the COVID hitting hard, people living in US, UK have got awakened. Otherwise, they were focusing only on lifestyle diseases like diabetes, etc. Now they know that if they do not curb infection, and with travel and other things happening, they would severely be hit. So obviously, we need to tackle these issues. What are those diseases which WHO indicated as top threats? Influenza, Ebola, measles, and you can see viral diseases, dengue, Zika, HIV. Believe me, even COVID virus has similar etiology. HIV is an enveloped virus and so is COVID. So you never know that viruses, how long they'll remain, how they are going to mutate, and how they are going to affect our future. So we need to be really ready on all the fronts. So be it diagnostic, be it preventive, where we are taking, say, vaccines, etc. And if we get affected, we also have to look at the therapy module. Now this slide is busy, but definitely it shows you which are deadliest of them all. These are the global examples of emerging and re-emerging infectious diseases. So in red balls, wherever you can see red, They are the newly emerging ones, like bubonic virus, influenza coming again and again and hitting hard, SARS, all the viruses, MERS, COVID, all are newly emerging. There are some which had become dominant, but they are re-emerging and they are indicated in blue. So you can see that gonorrhea, adenovirus, yellow fever, tuberculosis. Now I even hear that leprosy. There are so many patients. So we need to work in those directions. And then, of course, there are some which are deliberately emerging, like anthrax. So it can be a cause of even bioterrorism. So scary, but there is lots to work on. So why restrict yourself only to lifestyle diseases? Who is going to work for India? You and me. So please, I would say that if you have 10 students, at least 50% of them you should put on infectious diseases so that we come out with solutions before the world really, gets affected in a bad way and this human race gets eradicated. We don't want that. We want a happy planet. So though there is significant decrease in mortality, we are able to treat. We have some diseases. We have some therapies which we are repurposing. That's the reason why mortality is decreasing. But nevertheless, population is getting affected. So we need to work on it. There is struggle with ongoing pathologies. And that mutation which happens is leading us to think and rethink of the strategies which can be used. And that's the reason why Government of India has come up with drug discovery hackathon. So you need all of you have to participate in a hackathon to come out with solutions. And of course, the vast scale of global epidemic, which has been provoked by all the viruses which you have seen in the earlier slide also, forces us to look very closely at the territories from where they are emerging. And therefore, we need to curb even travel to those. I'm sure all of you would have blamed Mumbaiites and Puneites for this COVID. And why not? People have been traveling. And you can see what is the effect which increased urbanization is playing. It's playing a major role. In a single day, trains which connect Mumbai move more than 7 million travelers. And if you look at New Delhi, which is another metro city, and its metro system, metro trains caters to about 2.5 million. And with this type of a crowd, imagine if someone has tuberculosis, will you ever know? Answer is no. Same is the case. Now, if you have asymptomatic travelers, how will you know how to take precautions? In fact, there have been studies which have shown that nearly 40% population of New Delhi has been infected by dengue virus at least once in their lifetime. So these crowds you cannot contain. How will you contain the diseases? It's point to think. It's really time to think now for all of us. So there are huge number of Indians who continue to die annually due to even non-communicable and infectious diseases. There is dual burden, stress on the underfunded as well as under-resourced health system. We hardly have, doctors, now alternate therapy doctors also have been roped for as frontline workers. Even pharmacists have been roped in as frontline workers. Why? Because we are actually under-resourced. Sourcing always, in fact, funding always has been a problem. Though philanthropists have come forward to support, still there is issue. So infectious diseases do undergo unchecked. And then there will be resurgence. And obviously, COVID has actually taught us a lesson. You will be surprised. Look at this Indian map. And what I'm trying to show you is we do have diseases which are mosquito-borne or vector-borne, airborne, and waterborne majorly. And see, where is our Maharashtra? We are proud Maharashtrians, right? We have all vector-borne, waterborne, all the diseases which are prevalent here. So who is going to take care of this? Why can't we educate masses? And that education would happen only through social means. And we pharmacists have to take lead in this direction. You can see UP, Gujarat, there are, swine flu was a major one, but here, waterborne diseases like hepatitis, thyroid, gastroenteritis. Can't we do anything about quality of water? We can, but we have to give our own self-concerted efforts in that direction so that we can curb all this. India's deadliest infectious diseases are these. Of course, of these, tuberculosis is very, very high share, and this graph says it all. You can see that there have been deaths due to tuberculosis, and which is number is very high. And then there are others like acute respiratory infection, even acute encephalitis syndrome, vector-borne, hepatitis, etc. But tuberculosis stands tall. So we need to work in this direction too. And major reason why tuberculosis deaths are happening is people are not sticking to the therapy. Why they are not sticking to the therapy? Because we pharmacists have not given them a solution. We have given them dosage forms, but those dosage forms have to be taken daily, repeatedly. So many different tablets of so large sizes. Can't we give them something which is simpler, which can be taken once a month only? Can't we work in that direction? So our lab is working a lot in that direction now. And you'll see some case studies which have generated from our lab. So this again indicates the burden which these diseases are having in terms of mortality. This is for TB and this is for all other cases, which see, since 2017, rather 11 onwards, it's almost static. You don't see a dip. Even if there's a dip, next year you will see that it increases. So people definitely are at risk. Why tuberculosis is one of India's biggest public health? It kills an average 4 lakh Indians annually. And in fact, daily average over 1,200 actually is way beyond COVID fatalities. But have we thought that tuberculosis also needs to be tackled? Everyone is thinking COVID, but TB, major. In fact, Prime Minister has already in 2018 indicated, that we need to really put concerted effort in this direction. So there are many challenges to tackle. There are emerging infectious diseases. We do not have medical countermeasures. Drug resistance is on the rise because people are not sticking onto the therapy, leaving in between the doses. Obviously, when resistance emerges, you know that now, earlier it was just, we used to say, multi-drug resistance. Now we are saying XDR TB, against which none of the current drugs are working. So imagine such people if you are coming in contact with on a daily basis in trains, during traveling, there are all the chances that you will also get those strains. Really scary. There's social stigma. One needs to work at human-animal interface also. You never know. People are more and more, having pets. But if those pets have these infections, how will you know? And from animals to humans and from humans to animals, it's both sides. Many diseases happen. So one needs to be careful. Again, there's occupational exposure. All those who are frontline workers, now you have seen how many doctors have died. It's due to occupational exposure. And then, of course, there are some geographic factors which we need to consider. Health care funding, resources always is dwindling. Whatever amount is there, it is less. And this is something which we need to think of in future and be ready. So how will you overcome these existing challenges? You need to do in-depth research. Priority diseases should be infectious diseases, should be parasitic diseases. Work on cancer, doesn't matter. We need to tackle that also. But infectious diseases statistics are really scary. Develop advanced products. Develop more robust immunity protocols. How many of us in pharma are working on vaccines? Hardly any. Why? Because it's a long run. But we need to work, slowly we need to get into it. Improve hygiene conditions. So can we not have street plays and things like that to educate masses? In Mumbai, that was taken up, people used to spit on the road. And when they spit, obviously, infectious diseases will spread even through spit. Even if you say that they chew pan and spit, you never know if the patient is, they are patients or they are normal human volunteers. So there was fine, which was very, very high fine. People used to stand on highways in plain clothes and stop the taxis, auto fellows who used to spit. So such things need to stop. We need to practice and look at, we eat good, healthy food. There have to be safe sex guidelines and you have to create awareness. With this awareness happening, AIDS patients have gone down. And obviously, there has to be animal control also to prevent infections. So now coming to some of the research which we have done on infectious diseases, both in diagnosis and therapy. So we have worked majorly on malaria, or brucellosis, which affects both animals and human beings, fungal infections, bacterial infections. We have worked on vaccines, on diagnosis, etc. So I'll start with a case study of HIV, where stigma needs to be beaten. So World AIDS Day, Paiva Neto said, virus of prejudice assails more than the disease itself. So we need to work in this direction. And what is actually happening is there's HIV-related stigma. And it seems nearly 1 in 4 people say that HIV positive, if they are, it makes them feel dirty, it makes them feel worthless. So there have been many suicidal cases. So it may be for no fault of theirs, Sometimes through infected needles or infected blood transfusions, they can become HIV positive. It's not that it's only through sex. So typically people socially will look at this population, in a different way. So that doesn't let them live. So we need to do something for it. If you look at summary of global HIV pandemic, 2019 summary it is, there are about 38 million people who are living with HIV. And 1.7 million are newly infected there. And then there are about 690,000 deaths which have happened in 2019. So scary. Statistics are really scary. So we need to come out with technologies. So what we did, we are working a lot on microemulsion. So we thought, why not use that same platform and come up with a nanomicrobicide? And that nanomicrobicide which we'll be making has to be very, very cost effective. It should be an easy, industrially feasible technique and masses should be able to use it. And these are some of the Asia statistics. So what did we do? If you look at microbicides, there are people who are using physical barrier like condom, etc. Circumcision is a technique. Very few will practice it, but most of it is microbicide, which comes in this category of chemical barriers. So one needs to use microbicides, which have shown high acceptability also, and can be given as gels, tablets, vaginal rings, etc. So when we were doing literature survey, we saw that tenofovir had cleared phase 3 clinical study. And tenofovir, as you know, is anti-HIV, anti-retroviral drug, which was being proposed as vaginal microbicide. So we wrote a project to DBT ICMR saying that can we use herbal leads to make an antiviral which will be as effective as tenofovir. So what was the hypothesis? We had a very strong hypothesis there. This is what depicts virus. Virus is an envelope virus, as I mentioned to you. So there's a core. Within the core, you have RNA, and then there's a shell. And to the shell, you have GP120 attached to GP41. So if this virus had to infect human beings, it has to get fused with the cell membrane and then undergo uncoating, reverse transcription, make a pro-integration complex, and then get released in cytoplasm. Our hypothesis is that can we come out with something which acts as a fusion inhibitor? That means it does not allow virus to get fused to this cell membrane. And if it does so, obviously it has to act on this particular co-receptor, either CCR5, or it has to prevent the attachment, this particular thing. CD44 gets overexpressed during HIV. So it has to actually curb that. So with that hypothesis, we started working, and you'll be glad that we have come up with a very simple system wherein our M lipid, I'm not giving you because this M lipid, because it is in various trials actually. We are exploring it for n number of diseases. So we have made a microemulsion of this M lipid, and that has given us very, very high safety profile. So typically you need to actually look at how this acts on TZMBL cells. How does it behave? And then there's another assay, which is PBMC assay, which we need to perform. In both these assays, you try and understand that M lipid by itself has been proven to be safe. It's not cytotoxic. At the same time, it is giving us efficacy. Another testing which is to be done is beta-galactosidase assay. So this takes time, and therefore fast forward way, typically we do either P24 or we do beta-galactosidase. So when we did this testing for B-galactosidase and P24 assay, we found that M lipid itself has very, very high efficacy, which is micromolar level. So idea is, if your lipid itself is very highly efficacious, if you are going to generate microemulsions out of it, obviously they will also be highly efficacious. And over and above that, if you are going to put any synthetic agent in it or any herbal active in it, it will still become very highly efficacious. So we formulated microemulsion based gel, and that has given us really early stage inhibition in time of addition assay. Obviously, if you are making a gel which females specifically would be using, and majorly it's the sex workers, but can be used by housewives also, people use condoms. So it shouldn't happen that it is incompatible with condoms. So we also did condom compatibility assay, and we took 3-4 condoms from the market, and we saw that we formulated 2 types of gels, water in oil type and oil in water type, and both these gel formulations were safe, compatible even with condoms. Then we looked at, we had a hypothesis, but whether really it is going in. First, whether it's acting as fusion inhibitor, it did act as fusion inhibitor. Then, if it goes in, where does it go and reside? So you can see that water and oil was taken in the cytoplasm itself. So that means it can act even in the transcription stage. And when we looked at oil in water one, it can also target post-entry stage. So both oil in water as well as water in oil type were actually very, very effective even in the post-entry state. So though we started working as fusion inhibitor, so what we suggest is plain gel, which is without actually any of the actives, can be used as a microbicide. But if you want that it should be used for treatment purposes, you can load this particular gel with the actives and use it for treatment. So when we looked at anti-HIV assay in vitro, we got selectivity index 80 times higher. And when we say 80 times, that means it's much higher effective than marketed formulations. And in fact, behaves in the same way as tenofovir behaves. So in most of the cases, if you've seen my earlier slide, we had a positive control, and that was tenofovir. So then we loaded it with, this was a DBT project where we had said that we'll evaluate pre-granulatum, that is Punica granatum. You all identify this, right? Pomegranate. C. sinensis, which is tea, and C. longa, which is nothing but turmeric. So these three individually and in variety of combinations, we looked at their efficacy and we came up with a nanomicrobicide ME-based gel. Now, what is important is if you are applying it in the vagina, it should not affect its normal microbiota. So it should not affect normal lactobacilli, which is required. So we did those tests. We looked at condom compatibility. One chance accidental discovery was that this particular gel also had spermicide. So those people who want to actually, not have kids for a longer time can also be using this gel. And of course, it gave minimal to mild irritation in rabbit. That means it will not be irritant in human beings. So now, in fact, we are planning primate studies actually in US. So it will go to now monkeys, and then results are so very encouraging that it may go to even human beings. Another case study is of malaria, and you know that India is a hub for malaria, in fact, and we are definitely at a risk. So there is difference in the structure when you have a normal RBC, and if the RBC gets affected with the malarial parasite, you can see these knob-like structures. These are nothing but, calcium comes onto the surface of these particular RBCs. So we worked on cerebral malaria because currently there is nothing for cerebral malaria. What is given the market is artesunate injection, but that artesunate injection also is not very effective. You'll see in the consequent slides. So people need to be immediately hospitalized, otherwise they will go into coma. So what does it do is actually it changes the total RBC, becomes hardened. So when they become hardened, they are not able to move, they are not able to flow, so blood doesn't move. So obviously there will be coma resulting in death. So our hypothesis was, can we make nanostructured lipid carriers, which are NLCs, and I've been working in malaria for last 20 years. So given a lot of therapies to industry, so here our hypothesis was, can we make NLCs which would be the combination therapy as per WHO. So if you see WHO guidelines, these are the combinations which are given, and artemethyl lumefantrine is a combination which is orally given. But there's currently not a single formulation available as parenteral. And in cerebral malaria, you can't give anything orally. It has to be immediate. So we developed a dosage form, which was IV dosage form containing artem ether and lumefantrine. If you read this, what is marked in red, there's 100% mortality seen with cerebral malaria. Isn't it scary? So we don't have anything right now. So we thought we'll work in this direction. So what did we do? Yes, we developed anti-malarial combination NLCs of artemether and lumefantrine, and you can see that parasite count was 0 when we did animal studies. And that is what is required. And these NLCs have shown sustained release for both the drugs. So we want faster onset, which will come from the burst effect, and then we want dual effect, which will come actually from the prolonged effect. Then we looked at different dose levels, and we saw that even at 1/50th of the dose of artemether lumefantrine, which is taken orally, this has given us complete parasite clearance, 1/50th of the dose. And this is what marketed gives. You can see that marketed actually gives recrudescence. Then there's another study where first we infect the animals, allow the parasite count to rise, and then treat them. In that case also, our parasite count was at 0. And in this case, NLC at 1/10th of the dose could curb the infection totally. So this says that we had a real, very, very potent system which has given us activity. So now was the time to do the study actually in CM, that's cerebral malaria. So we had to actually use special mice, C57 mice here, and 50% of the population gets affected with CM. So we had to actually validate a protocol and then use. I think the next slide will give you all these technologies, whichever I'm sharing, have been patented, and there are some publications also. Now in this slide, I have shown why our system is the best. One is that you will see this red color dye we have actually incorporated in NLCs. If you look at these, there are two types of cells. Normal cells which do not have nucleus. You know that normal RBCs don't have a nucleus. And then these are RBCs which are showing nucleus. So that means these are infected RBCs. So normal RBCs, infected RBCs. When I'll play the video, you'll see that most of this red colored NLCs go into infected RBCs. So there's selectivity, and we have published a paper which you can see here in biomaterials, and that paper, and there's another paper in IJP, Indian International Journal of Pharmaceutics, which talks about all the different parameters, why this selectivity we have got. So I'm playing the video. Note, normal ones do not have nucleus, infected ones have nucleus. So this dye, this is live imaging. And when live imaging is done, you would see that wherever there's granular mass, wherever there is nucleus, they are going and residing. But they are not going into the normal RBCs. So this is something really very, very astonishing. And these videos, when I'll play, you will know what I'm talking about. You know, when there is cerebral malaria, and these are C57 mice, this is what happens with their gait. So I'm not showing you the infected ones. Their gait is really very, very bad. But I'm showing you, even after treating them with marketed formulation, you can make out their gait is, they are not moving at all. Can you see how they are moving? So there is brain which is getting affected, right? So they are also comatose. Just like paralytic animals, they are moving. And what happens when we give our formulation, which is artemether and lumefantrine? This is normal movement which is there of these mice. So this particular study has given us real good confidence, and now these are undergoing, this is only preclinical data which I'm showing, but currently this is undergoing actually clinical trials for both P. vivax malaria, which is very, very common, as well as cerebral malaria. So we'll move on to the next one, wherein we have worked on One Health concept, and this was a grant from Bill Melinda Gates. And here we are talking about brucellosis, which definitely is a zoonotic disease, and you can see that $452 million US, in fact, grant, in fact, people have to put in this much money to get treated, which is huge. So if you look at brucellosis, it comes through all the animals, and from animals through their dairy products as well as meat products, as well as the farmers and doctors who are working very closely with them, it will get transmitted. So severely it hits everyone. burden is too much, and it is in the neglected zoonotic diseases. And that's why anything which is neglected by anyone, I pick it up and will start working on it. Because why should even 1% of population suffer? We need to work to see that everyone gets a fair chance to live. So what did we do? We made a point of care testing. When we say point of care, typically right now what is being done is you have to take blood and plasma samples, send it for RT-PCR, just like, COVID, or do ELISA testing. What we suggested that we do this testing from animals and human beings from saliva, urine, milk. So non-invasive. So that becomes point of care. That means even the people who are raising these animals, they should be able to do this testing at their end. So these are some of the features which we wanted. And this is a POC, that's point of care diagnostic market, which also is 28,379 million. Huge, huge market. And infectious diseases, you can see here. Obviously, you know that people are working on diabetes. So 61% share is by that. But why can't we reverse the situation? Infectious disease, can't we locate who are the people who are having TB, who are the people who are having leprosy and other diseases? We can very well do that. So there are different methodologies, instrumental methods, non-instrumental methods. So we wanted to work on a cheaper technology. So obviously we have looked at non-instrumental method. And what did we do here? We have nano sensors. We have designed. And obviously, we've taken a patent for this also. And one of the patent, in fact, right now, the project which got sanctioned is on this. The COVID testing is on this basis. So we have designed nano sensors, which will be having 3 different things. So they'll have nano system, which in our case is silica, which is the cheapest. People are using gold. So we thought we'll use silica. Silica, you can get it even from, rice husk. So it is very, very cheap material. We have a fluorophore, which we have incorporated so that you can visualize. And then, of course, you have to have antigen, which in this case is LPS. So this is how we designed a lateral flow strip. So you do have a sample pad wherein you will be applying sample. Then there is a test line, there is control line, and there is adsorbent pad. So this adsorbent pad function is that whatever excess is there, it will absorb. Simple principle, you are applying sample, be it from urine or saliva or from milk, onto the sample pad. It will move. It's lateral flow kit, so it will move further. So obviously, you know that we have FSNs, that's fluorescent silica nanosensors here, which are with antigens, so they will move. So if there are antibodies already generated, that means there's some infection, they'll move and this will glow. So if it is totally positive, this will glow. But if it is negative, both lines will glow, because we have loaded even fluorescent silica nanosensors here also. What I'm trying to show you in this slide is, what is its sensitivity specificity? This is our ICDT. I put it as ICDT. Okay. Diagnostic test developed at ICT is ICDT. Compare it with ELISA. See, it compares with ELISA. But ELISA is costing you 2,500 rupees and ICDT is costing you 5 rupees. So that's the difference. And that's the reason why this was also awarded by Gandhian Young Technology Award. And in fact, my own student got 15 lakh of rupees to take it to the next level. So we have tested them in animals. We have tested them even from, see the results of PCR. So absolutely matching. So we have tested now in animals, tested them in some human beings. So the grant has been given to test more human beings. So on basis of this, of course, we did some work with the vaccine also, and this was Bill and Melinda Gates Foundation, which gave us a grant to develop a mucosal vaccine. And again, on this basis, we wrote a project and we have got a vaccine, which will be making, even for COVID, which will be a nasal vaccine. So in this case, what we have done is we have used xyloglucan as a polymer and designed nanoparticles. And if you can see here, we have done a lot of immunogenicity studies and bacterial challenge studies, which were all done in US, because we don't have class 3 facilities. So this study, we can do it here. We can easily do it here to look at, what are the titers, IgA, etc. But when you have to infect the animals, they can infect all other animals which are in close vicinity, and therefore class 3 was a must. So this study we did in US, and the results are really very, very highly encouraging. So study has revealed that we are getting both type of responses, innate as well as acquired. That means long time immunity also you are getting. At the same time, because you're giving it by nasal route, we wanted to see that it should not be written to the mucous membrane. So obviously, this is our formulation. NV50 is our formulation. And you can see that cilia remains intact, just as blank formulation, placebo formulation. So that has given us real good confidence that we can go ahead. Even when you're giving booster doses, which have to be given in case of vaccines, the NV50 retains a nasal cilia the same manner. So that is a good thing. And you can see the results of bacterial challenge, and NV50 has given us real good results. And in fact, our collaborator wants to take it further now. These are also in small animals, but he wants to do it in now higher animals. So we have shown that there are colony forming units which get actually reduced a lot in all the tissues when we are inducing infection by B. abortus. So all these benefits we have got, which I have already listed. Mice which have been primed, boosted by these, have given both cell-mediated as well as humoral immunity. And that was our purpose. And obviously, we have a patent in this. So with this, I would like to stop and just to tell you that our lab has all the facilities in-house. By way of writing grants, we have got and equipped our lab. And you can see that our people really, my main aim is to keep them happy. If they say that, madam, we don't have this, I'll write a grant to get it. So they cannot complain that they can't work. These are some of the technologies which we have transferred. And in fact, this one is undergoing phase 2 clinical trials even for COVID. So stents we have marketed in 65 countries. These are nano-based products. What I'm showing are all nano-based products which we have developed. And all that has been possible only because we are focusing. Each student is taking this oath before they start working, so that they will focus on whatever problem has been given to them, so that they can reach out to masses. They can affect patient population, and that patient population would be thankful to each one of them. Our team, I tell you, they are all gems. And thanks to institutes like you that you all train them and send the best to us. Thank you so much. I would like to end by saying science knows no country, because knowledge belongs to humanity. And that's the reason I never say no to share knowledge. And that's the reason why each of the student who is at ICT would do that too. Because finally, knowledge is the one which is going to eliminate the world, said Louis Pasteur, which is right till date. Thank you so much.
Thank you, madam. Thank you for most informative session. Madam, you touched upon various aspects, starts from non-sterile dosage form to sterile dosage forms. Whatever research going on in the VBP laboratory, it's awesome. And in fact, once in a week, I am going through your website, once in a week at least. What is the updates in that? Yes, madam. Once in a week, I am going through your website. What are the updates available on your website? So you're doing wonderful, madam, and this is most inspiring session for we budding pharmacists, we budding researchers or budding academicians. So hats off to you, madam. You discussed various aspects, various topics working in your laboratory. I think you have at least half-century students worked under your able guidance as far as PhD is concerned, and hope there will be 150 minimum students in coming 10, 15, 20 years. So thank you, madam. I would like to share one quote. Google is working on self-driving cars and they seems to work. People are so bad at driving cars that computers don't have to be that good to be much better. So I request all the delegates, you should take at least 5 to 10% of inspiration from VPP ma'am, so that you can work in your laboratory on the same direction, so that your car will not change the direction, your motor will not change the direction, and I'm sure VPP ma'am is always 24/7 ready to help anyone. No matter the person is from Nashik, no matter the person is from Mumbai, no matter the person is from Maharashtra, that doesn't matter for, at least for VBP ma'am, I know. She is always ready to help any researcher. So thank you very much, Dr. Vandana Patravale ma'am, for your informative and motivational session. I'm thankful to Mrs. Anupama Paranspe ma'am for this session. I'm thankful to the coordinators of the session. I request all the delegates, if you have questions, please raise your questions so that you will have direct interaction with the VPP ma'am. So please raise your questions if you have. Any question from audience? Any question from audience? I'm 100% genuine. Yes, madam. There is a question from Professor Vilas Jagtap. How ideas or problem statements comes to mind?
So thank you, Dr. Jagtap, for that question. So as avid reader, someone please mute your mic. There's a lot of disturbance. Yeah. So I read at least 5 to 6 papers every day. And what I try to do, as I've already indicated, that I take up challenging work. So I look at neglected diseases, I looked at orphan drugs and see whether I can connect dots. So majorly, we all know, even DBT site and DST site, you will see they have given problems which are thrust areas. And what becomes thrust area for a nation? Which are the problem the country is facing. So I look at that every day and then pick up, if my country is having this particular issue, is there some way, by way of formulation, because that's where my expertise are, is there some way that I can contribute? So that gives me idea about the major goal, the broader goal, that yes, I need to work on, say, malaria. Then comes to how in malaria I can be useful. Then I look at, okay, WHO has given some guidelines, right? But what is it if artemethyl lumefantrine was there oral? Why people have not formulated parenteral dosage form so that cerebral malaria can be tackled? So I go myself and personally look at the physicochemical properties of the drug and try and understand, are there any challenges? Are they safe? So they are safe, but people have not worked because they are not able to solubilize. So we now, by 30 years of research experience, we have many technologies. So then we look at which technology can solubilize these drugs, and therefore, can it cater to the problem? So from broader thrust areas on our nation's websites to goal, which I have to achieve in 3 to 5 years' time, to shorter goals, which I need to actually achieve in a 6 month to 1 year time. Another thing which I tell students is, if you have taken up a problem, don't leave the problem on the way. Goal should remain the same. Ways to reach that problem may be different. So if at times, for example, people have formulated, say, nano emulsions and seen that they are not effective. More than that, I'll say that they are irritating because you are using so much high surfactant concentration. If that is the case, look at something else which uses lesser surfactant, because majorly it's a placebo which is giving that irritation. So I hope, Dr. Jagtap, thanks for raising that question, but I hope I have answered your question. Shilpa Bilagaonkar is asking, how much time is taken to go to clinical trial from formulation development? So ideally, if you have done formulation development and you've done prototype formula, by prototype formula, I hope you know that you have completed 6 months accelerated stability study as per ICH. That's what I'll call it as prototype. After that, you have to have preclinical studies done. And these preclinical studies, definitely one would be with respect to your pharmacokinetic and pharmacodynamics, but also you need to do acute toxicity, you need to do chronic toxicity, genotoxicity, mutagenicity, and carcinogenicity. So if it is a new product, if it is a generic product, you need not do that, because in generic product, you are using excipients and drug which is known. So in that case, you don't have to do. And in fact, if you are entering into market 4 years after the innovator, you don't even have to do clinical. So in that case, all you have to show is your product is matching in Q1, Q2, and Q3 parameters. If you have not read that, I would request you to read ICH guidelines. It clearly says which quality parameters you need to match. So Q1 is qualitative formula, Q2 is quantitative formula, and Q3 is microstructural details. If you match that, you don't have to do bioequivalence also. Leave apart clinical trials. But yes, if it is a new innovative solution which you are proposing, you need to do in-depth preclinical studies, in which you'll at least spend about 2 to 3 years, and then they'll go in clinical trials. There was something else which flashed while I was answering.
Yes. There is one question from Dr. Ramdas Doas. He is asking about COVID vaccine on which your team is working.
Yeah. So as I said, we already have a technology which is for a nasal delivery, and that was our Bill Melinda Gates proposal for brucellosis. So we already have developed a nano vaccine platform in which we have added antigen for brucellosis. So what we have done now, we've understood pathophysiology of COVID virus. This is also, again, an envelope virus, and all of you know that it has spike proteins onto the surface. So what we have suggested is that we will encapsulate that spike protein itself, which as such is not, contagious. So spike protein, encapsulate it and give it by nasal route. So DBT initial screening is done, and technical sanction they have given. I'm just waiting for money to come and students to resume, because most of them have gone to their hometown. So this week we are actually starting. Monday onwards we are starting. So it's a nasal vaccine. So I don't believe in pricks. So I feel that it should be something which can be given to masses. And how will you give it to masses? How will you reach rural areas, interior areas, if you have lyophilized vaccines which are not stable, you cannot even transport them. It needs cold chain transport. And most of us fail there. We don't understand, problems of rural India. We need to understand those problems too. So it's not that only city people should get vaccinated, isn't it? Unfortunately, people have run away from cities, and everywhere there's a spread. Government indicated, we stay put wherever you are, stay there, but people didn't listen.
Thank you, madam. Thank you. It was very nice session. I'm thankful to Dr. V.V. Patravale, madam, on behalf of Gokhale Education Society, Sir Dr. M.S. Gosavi College of Pharmacy, and Nashik, Indian Pharmaceutical Association, Nashik branch, for her valuable and motivational talk. I will be always happy to call you for next sessions also, madam, in future. And
people will complain, I'm sure, Dr. Prashant. Already people say madam takes time. So now this time I've kept it 55 minutes.
Yes, madam. Yes. So I'm thankful to you, ma'am. I'm thankful to Mrs. Anupama S. Paranspe, ma'am, for moderatorship. And I'm thankful to both the coordinators. With this, I would like to conclude this session. All delegates are requested to stay tuned sharp at 4:30 for valedictory function. Thank you very much. Thank you.